Hello, hello, and good afternoon, everyone. My name is Shaniqua Morales. I am a patient safety nurse, a perinatal patient safety nurse, and I want to thank you all for joining. We're going to give it maybe another minute or two, and then we'll get started with our panel.
Thank you.
You're welcome.
How are you doing today?
I'm fantastic. How are you doing today?
Good. What a
And
beautiful week to have this presentation.
Yes, we're ending with the best discussion panel, in my biased opinion. We're going to end our Black Maternal Health Week with a bang. I'm excited about that. How are you doing, Rakaya?
I'm well, very excited to be here today. You can't see, but we got our promo.
Oh, I love it. Oh my gosh. Dr. Hines, I have that shirt. I should have worn that shirt.
We were like, do we hold the shirt up the whole entire time like this?
You angle your camera a little bit, right? Oh, I have
Right.
the same. Next
Perfect.
year,
That's all.
we're all twinning. How about that?
That's right.
Perfect.
Right?
Right.
And we'll have the attendees.
Triplets.
We'll give them a little heads up too. They could twin with us.
Right.
I love it. I love it. So I just want to welcome everybody into the room. We have such robust discussions prepared today. So if you ladies are ready, we can get started. What do you guys think?
Beautiful. Absolutely.
Excellent.
We could get in, and if people, please use the chat if you have questions. I know we can't see you, but the way that we're going to communicate with you is through the chat. So if you have any questions, put it in there and we'll get to it. This is kind of informal but formal, so let's call it in.
Excellent, excellent. All right. So for those of you that have joined us today, we really want to thank you for taking the time to share your time with us today. Our goal is really to empower you with information that's going to help you and your family and your community really build confidence in your birth choices. And so I'm really excited to be here to moderate for these two incredibly knowledgeable and experienced certified nurse midwives. I have Dr. Heather Hines and Rakaya Watts. So we have some robust conversations. So I'm going to get started. We're just going to jump right in. So my first question, we hear this a lot.
Hold up.
Oh.
Let's just tell them where we are in the world, and then you can jump right in.
That's a great idea. Thank you.
Yes, beautiful.
I forgot we're national. This is all virtual. We could be anywhere in the world. My bad. You are absolutely right. Dr. Hines, where can we find you in the world today?
So I reside and work in Suffolk County, Long Island. I go by the pronoun she, her. I have my doctorate in midwifery. I have been a midwife for 24 years. I am the program director of education in the midwifery program at SUNY Stony Brook. And I have a beautiful concierge community practice that offers care to low-risk patients that deliver home birth or catch babies at SUNY Stony Brook.
Awesome. Love it. Thank you. So you are in Long Island, New York, right?
Yes.
Excellent. Rakaya, tell us a little bit about where we can find you.
Yes, so I am a practicing midwife here in Suffolk County of New York. I reside in Nassau County, so I've got my foot in both counties. I've been a midwife practicing for the past 13 years, and currently I am the division director of the midwifery practice at Stony Brook University. So that's where I am now. I'm in my office doing this, and I'm very excited to be here today.
Thank you. Thank you. And I, Rakaya, am not in Suffolk County, but I am in New York. However, I'm more like you. So I live close to Long Island. So I have my home in Long Island. But I work in Brooklyn, New York. And I have been a patient safety nurse for a little while now. And I love it. I've been a nurse, an OB nurse for over 10 years. And so I've done a lot of different, I've had a lot of patient experiences that I'm really happy to say I was able to really support them. When you're able to just support a family through their delivery and help make it the best experience that they can go home with, that to me just empowers the family in such an incredible way and sets the tone for their parenting journey. So I love meeting birth workers and advocates who, have the same values and want that same goal for for their patients. And so I'm happy to be here with you guys.
Oh,
Feel
wonderful.
free also in the chat if you all want to share where you're from, because I'm curious to know
Please,
where
me too.
our attendees are from. So feel free to put that in the chat. All right. Oh, yay. We have Orlando, Florida, and Minnesota. Excellent. Washington State. Where else do we have? Ah, I love this. It's always, thank you for that, Dr. Hines, because it's always cool to see the Virgin Islands.
Nice.
That's
What? That's
awesome.
Lovely.
That is. I love it.
But
Philadelphia.
think
Yeah,
about this. Think of the breadth of this organization and how it's reaching people even down in the Caribbean. Like that's awesome. Like technology
ab-
today is really helping to get information out there, bring people together, and this is wonderful. So thank you all for putting that
absolutely.
in there.
Absolutely. And I love that we come together, right? Like you break down those silos
Right.
so that we can collaborate together and empower each other together. That's awesome.
Yep. Beautiful.
Excellent. All right. So let's get started. So I put together some questions really around just like I said, really helping our communities build confidence in their birth choices. What I've seen in my experience is we don't always know what questions to ask because we don't know what we don't
Right.
know, right? And so I think the biggest key is understanding what questions to ask and when and how to make those decisions. So I kind of tailored my questions around that. So my first question will go to Rakai. Actually, either one of you can answer. It's very organic, right? But can you explain the roles of various healthcare providers involved in childbirth? So particularly like midwives, OBGYNs, registered nurses, and doulas.
Absolutely. So I think all the names of the roles that you mentioned might be involved in someone's care. If you're thinking about who's going to provide your medical care, your options are to have a certified midwife. So that could be someone who's also a nurse, like Dr. Hines and I, but doesn't have to be a nurse, or an OBGYN. So those people are responsible for not only caring for you during your pregnancy and birth, but also your baby. So in a labor situation, yes, to support you, but also to be mindful of what's happening in your labor, monitoring that fetus, monitoring the progress of your labor, and all those medical things. Your registered nurse will likely be in the room to support you. Typically, that care tends to be one-to-one in most hospital settings. And that's a person who's also going to be looking at your baby, your pain, things that are happening with you. And then there's a doula, and we love doulas. And the way that doulas are different than any of the other people that I just mentioned is doulas are really there to support you. They are that non-medical person in your team who's going to make sure that you have the support that you need. That might look like helping with positions, movement in labor, getting you through contractions, maybe at home, in the hospital if you're choosing to have a hospital birth. But that person who's not worried about the fetal heart rate tracing, your blood pressure, what your cervix is dilated to, they are there to support you. So very often we get asked, if I'm choosing a midwife, do I still need a doula? And our answer is absolutely.
Yes.
Because your doula is going to support you in a different way than your midwife. And we will all work as a team to make sure you have the best birth experience.
Yep.
Right. Thank you, Rakai. Is there anything you want to add to that, Dr. Hines?
No, I think it's very important to figure out what you uniquely need with your team. Some roles are not interchangeable, right? You can't change out your nurse for a doula, and you can't change your doula for a midwife, and you can't have the physician and the midwife unless that's the type of practice that you're working in. They all have their unique roles, and each role is guarding a certain part of your healthcare that's going to help to ultimately have, good outcomes and that vaginal birth.
Excellent. Thank you. And I think it's important to make that distinction. I started out my career as a doula, right, as a birthing assistant, and then I became a nurse. And so when you're trained in different scopes and different areas of expertise. So it's important to make sure that, to your point, you have that excellent team that's going to come together in those different roles, those different strengths to support your birth and your labor, but also your prenatal period. And oftentimes your postpartum period, because there are also postpartum doulas, right? It varies. So
Correct.
thank you for that. So if we're talking about, selecting like a birth provider, understanding your team and making empowering decisions around that, what factors expecting parents consider when they are interviewing or selecting a provider? What questions should they ask to make sure that those providers align with their birth preferences, their values, their goals, and essentially a healthy outcome?
Okay, I'll take this one, and then, Rakaya, jump on there if I miss anything. I think people should, and I think this is important for me to say because I think people lose the understanding that healthcare is money. So if you think of your insurance as money, you can take that money and go wherever you need to go, right? So don't get caught up like there's an office down the road, I can walk there, I want to go there, but they're abusing you. You don't stay just because you think that it's close. So some of the things that you want to align yourself with is an energy that aligns with your soul. So does the provider, let's start with the easy stuff. Can you get there easily, right? Or do you have to travel 2 hours to get there, right? Because that could be a hindrance. Do they have an office that is friendly? Is it a phone tree, right? Some people get turned off by a phone tree. Is it a place where you can get in touch with a provider right away? Or it's one of those offices that God help you after 5 o'clock because you'll never ever find a provider. Does that office align where there's 2 people that you're seeing, or is it 15 people that you're seeing? Do you care who you're seeing for your care, or do you really want to have an intricate relationship with one person and that's something that you want? So a lot of OBGYN midwifery offices could be anywhere from 1 or 2 providers, or you're seeing a group of providers. Does that matter to you? Does this practice have statistics, right? So when I talk about statistics, I'm talking about what is their vaginal birth rate? What is their primary first-time C-section rate? If you are trying for a vaginal birth after cesarean section, does this practice support vaginal births after cesarean sections, right? What is the episiotomy rate? Now, we already know that ACNM, which is our governing body, the American College of Nurse Midwives, and ACOG, which is the American College of Obstetrics and Gynecology, does not recommend routine episiotomies. But let's put this throughout the world, because we even people have from the West Indies here. There are still some practices that are cutting the vagina to facilitate babies coming out. So you might say, do you guys cut episiotomies? And like, yeah, everyone gets an episiotomy. That might not align with your soul. How does the practice feel about doulas, right? And I think as I'm going to put this out there every time, every birthing person in the world needs a labor support doula, postpartum doula, a doula in their life. And if there is a practice that feels like doulas are interfering with care, then that might not be the practice that you want to go to, because your doula might be your eighth boom king and they're going to advocate for you. And if your practice is thinking of them as an enemy, then that's not the practice for you. And some other things is, if you're not on the weekends, who's covering you? Because you want to know, do you do 24-hour coverage, or does on Friday, Saturday, and Sunday, you're on this like weekly rotation with 4 other practices, and you might, if you're on that weekend, not get your provider. You might want to know that information, right? So I can't think of anything else.
Listen, that was beautiful. And for each of those things, when people show you who they are, believe them, right? So if you bring these things up and someone sighs, or they turn their back, or they make a comment, don't ignore the red flags. We don't want to end up, as we say, with United Nations in your 38 weeks, because so many times you brought up things that you weren't heard, you weren't listened to, or you were told, well, maybe we'll see. What does your practice believe with vaginal birth after C-section? Well, it depends. Right. And then you get to a point where you're towards the end of the pregnancy and you realize that all those things that you asked for that were maybe you weren't heard, or were poo-pooed or pushed on the side, and now you're at the end and you're realizing you're likely not going to get the things that are important for you. So please, when you ask these questions and you get responses or no response, you take them for face value. Believe that people are who they say they are. And if someone isn't going to support it at 10 weeks, they're not going to support it at 40 weeks. And then you're in a position where you're trying to transfer late in the game. So believe people and know that you can find care somewhere else. I applaud the birthing people who transfer at 32 weeks and 34 weeks because of exactly what we're talking about. I thought it would be okay. It was close.
Mm-hmm.
It's where my mom went. They do my GYN care. And then they got to a point where they realized, you know what? I mentioned birth plan and doula, and the person kind of walked out the door. Or the newest thing that I've seen on social media, someone had posted on their labor and delivery unit, due to short staffing, we will not be working with doulas or honoring birth plans. Just posted on the hospital door. When people show you who they are,
That's where
believe
they are.
and know that
Yep.
you can find a provider. Keep looking, keep looking, keep looking, keep looking.
Yes, Leslie. I see that Leslie put on there, episiotomies are rarely done, but they're done in emergency, right? So it's important for people to also have an active stance in their care. It's a give and take. If you're going to a provider who is telling you what you're going to get, I'm sorry, I don't even get.
How do you know?
My mother doesn't even tell me what to do, right? So, like, you're just not going to tell me. But if you're going to give me the evidence based on why something is being done and have us come up with a consensus of this is kind of what I want or not want, I think the dictator type of care has gone out. We're in the new age of collaboration, right? We give you the evidence base. And when I say this, I'm talking about midwifery and obstetrics, because everyone's moving to that informed decision-making process, right? So we tell you what the evidence is, we answer your questions, and then we come together with a plan that's not just for me, but for the team. And the team is you, your partner, and me, and we figure that out. And we make sure it's documented everywhere so that people know what your wishes are, and it doesn't need to be repeated a million times. So those are some of the things that you want to have in a provider.
I think this is the best answer I've ever heard from both of you, an energy that aligns with your soul. Like, there is no better answer than that. And Rakaya, to your point, if they didn't hear you, communication is like 95%. It could be a little bit more, but 95% nonverbal, right? We're looking at body language. We're feeling vibes. If I say, hey, good morning, or I say, hey, good morning, it's not the words, right? It's the energy. And
Correct.
so believing them and trusting yourself enough to know, I don't really like how that made me feel. Because to your point, you said perfectly. If they're not hearing you at the beginning and your first prenatal visit, right? Then they're not going to hear you at 10, 32, or even postpartum. And postpartum, we know that there are really high rates of pregnancy related deaths, and that goes up to 1 year postpartum. And if you don't feel heard in your postpartum period, that can, at any point in your pregnancy, it can be life or death, but especially when you're feeling pain or when you can't breathe, or maybe your blood pressure is high and you don't know, but something's wrong and no one's hearing you. So I love that. That was the best answer. Wow, that was beautiful. It doesn't get better than that. So absolutely, I love that. What is my next? So if we're talking about even when we're talking about, so we talked a little bit about just things that they should consider. What else is there? Anything else that they should ask? Any specific questions, top key questions that people should ask when they first learn of their provider? And if they are, let's say they're in rural areas, because we do have what's called maternity deserts, right? And then we have other things like maybe transportation. I know out here in the city with the Bronx, people can't necessarily get around as easy, right? Or in Brooklyn, yes, we have the subways, but if you miss your train, you're going to be late to your visit. Those kinds of things. What are some things that you would recommend people that, if they do have to go to a provider that they don't particularly, vibe with, what are some ways that they can advocate for themselves? If it is based on their insurance or based on location and those kinds of things, some people do have to make those decisions. What would you advise them of? How can they advocate for themselves?
I think the role of childbirth education comes into play here, which we would recommend for everyone, but especially if you're stuck in a place where you feel like you're not being heard, right? Then you want to do your own research and not just Dr. Google, right? You want to try to find a free online childbirth education course, see if you're a community library, if a La Leche group, if there's someone in your community that's offering. Maybe there's someone who's doing a sliding scale depending on what you can afford to pay. They're obviously in-person, virtual, but educate yourself. So when you are aware of what normal looks like, what the expectation, what language looks like, you will be able to come back to your provider and advocate for yourself. And whether you're with a provider who you feel confident and safe with, or you're stuck in a situation, always advocate for yourself. I tell our midwifery patients now, when you come into the hospital, if you didn't want to have an IV, right? And we are in the routine of people come in and the nurse just comes in and she starts to do something, don't think that she is necessarily intentionally giving you something that you don't want, but everybody has a routine of things that they do. So if you don't stop and say, you know what, I don't think I want an IV. I spoke with Rakaya about it before. She's good with that. Most of the time that information can be received well, but people won't necessarily offer you things that you're looking for. So sometimes it's you saying, you know what, my baby looked good on that tracing. Do we have to keep the monitors all the time? For your nurse to be like, you know what, I can talk to your provider. Maybe we can monitor you intermittently. Or you're right, we don't have to have the fluids going. But that might not be things that are just volunteer for you. So even when you are with a provider who is listening and you feel safe, if there are things that are important to you, you got to speak up for yourself.
Absolutely. And I just want to tag team on that because Rakaya said that so beautifully that I just got 2 periods and a comma to put in. The thing is, your support person also needs to be educated. Whatever you're doing, make sure your support person is educated too, because 50% and 50% gets 100% of understanding of what the normal is, and you both can lean on each other. Once again, I put plugs in for doulas. It's important for you to also have that doula, someone who knows your wishes intimately, and regardless of pain or stress, they're going to be able to advocate for you. And I always tell people, sugar gets bees more than vinegar. So starting with a smile, speaking in a tone where you're not being condescending, but just wanted to let you know it's been 20 minutes and you said I needed 20 minutes. Can I get off the monitor now? Or can I wait till my midwife gets here before you draw the bloods? I want to talk about IV access. Or my baby is looking fine on the monitor. Is it okay if I walk around for a little bit? And nowhere in the world right now, people should be not eating or drinking anything in labor if they're in a normal labor, if you're at a hospital. If you're at a home birth, listen, do you in your kitchen. But you should be able to get your ice chips and your juices and your clears. It's really knowing your options. And the days of surrendering our care to people is gone from the 70s. Most of the people on this panel don't even know where the 70s was. Everyone nowadays has YouTubed something, has Googled something, knows the Bill of Rights, and got 2 lawyers in their back pocket. It's important that we advocate for ourselves and figure out the best way that we can negotiate this process. Because guess what? Brown and Black women are dying. So we need friends, we need allies, and we need the education because that helps us to get the friends and the allies to get the appropriate care.
Amen.
2 periods and a comma. Snaps. I love it. Not much for me to add there. I love that. I think I do want to just say the empowerment comes because, we look at all these stats, we look at, the rates of us dying and the education and all that kind of stuff. And we have very educated women, right? Like that, and birthing people that, it's not necessarily the education, it's asking the right questions and being educated about what to ask and what to know. And so I was in a session last week as a panelist, and we talked about knowing your own body, right? And to your point, understanding where you are in your physical, in your pregnancy and in your health journey. And so that's really important, and having all those questions answered. And I would even say, to your point of doula, is bring your doula to your prenatal appointment so they can meet. Everybody needs to meet, right? Have those conversations and kind of get the vibe and have a plan. But I think to your point, Dr. Hines, like you said, everything is just a conversation. It doesn't have to be charged. Sometimes when we're fearful, I know I can get very charged, and I have to remind myself, like, it's just a conversation. It's just a question I want to ask. And that approach, to your point, is going to bring together your birthing team a lot more cohesively.
Right. So take that even a little further.
Yeah.
Right now we're in a place of trust. Brown and Black people don't trust providers, right? Exactly. So starting off a conversation with kindness and love, like, listen, in order for us to really have a good relationship, we need to trust each other. So trust takes time. Trust takes patience. And trust takes give and take. And the days of carrying a chip on your shoulder, providers, I'm reaching out to providers, that day is gone. We need to align ourselves in trust so that our patients can give us all the information.
Yes.
In 2021, Rakaya and I did an article on risk assessment, right? Risk assessment is the way that you get help to mitigate problems that can occur in people, GYN, pregnancy, postpartum. But guess what? No one's going to give you their intimate tidbits unless they know that you have time for them, right? They're not going to trust you with their family history if every time they talk to you, you're at the computer typing instead of looking at them and talking, or every time they ask you a question, you have your hand on the handle of the door because you got to go. I'm just another patient. But if we can turn that around as providers and sit down and talk to the patients, if the patients can then say, can you just give me one more minute? I know you probably have a panel and you're overbooked, but this one small piece of information is important. It might save my life. We both all have to meet in the middle. So the patients need to give themselves, the providers, a little bit of time, and the providers also need to establish trust so that patient will give them that integral piece of information.
Absolutely.
5 times likely to die in birth and postpartum. We really need to allow time to get to know our patients.
Absolutely, 100%. I do have some questions that are going to actually lead to my next question. The first one says, how helpful are Black men as advocates in the clinical space? And that's really was my next question. How can partners, family members, how can they support them during, what are some ways that they can advocate for their loved one?
Listen, have a pad and pencil, pull out your iPad and open a note. And every time your significant has a question or a concern, write it down and make sure at the visit, be like, okay, is this question and answer time? Listen, I love a spouse that be like, we got questions, right? Because that means they have their best, which is their spouse, safety and concerns at the front line. So I think by writing down questions and stuff, that's a great way. Come to the visits, right? When they say the weight is, I'm just making this up, 123, and now it's last week and it's 150 this week, be like, wait a second, did the scale move? Did she really put on 20 pounds in a week? Those are some ways that, because remember, our significance are our support and our strength. So give them roles so that they can support. They're not doulas. Husbands and spouses and significant others are not doulas, but they are the support for that birthing person, postpartum person, because the placenta causes brain loss. So they're the extra brain cells to help them remember stuff.
Absolutely. Rakaya, anything you want to add to that?
Yeah, so I think we mentioned this before, but for childbirth education, we're not just talking to the birthing person, we're talking about that support person so they can be involved, so they can learn the language and the lingo, and that will help with them advocating. I also try to remember in visits to address the support person. So if I'm talking to the client and we're going back and forth and they're done, to turn to the support person and say, do you have any questions or concerns? Or, when I was talking to her about that, you made a face. Does she really not drink water? That sort of involve them in the care. It makes us so happy to see support people during the visits, not just in labor, because then that trusting relationship that Dr. Hines was talking about isn't just with the patient and the provider, it's with the family members. So if the partner trusts you as well, that's going to lead to an improved experience for all.
Absolutely. And I think that's essential, right? When I walk into a room with my patient, even as a nurse, as a labor nurse, I want to make sure I bond with not just the patient, but with the people that she trusts or that birthing person trusts, right? Because clearly they're in the room because there's some anxiety and there's some support that this person is going to get from her support team. And if I am creating this tension between myself and the support people, that clearly that the birthing person or the woman is going to pick up on that energy, and it does affect their experience. And so I'm always in a lot of these trainings. I do so many trainings with nurses. To your point, one, to make sure that they understand, that we understand as nurses the evidence-based practice and decision making according to best, gold standard practices, but also to say, hey, listen, this is all nonverbal. You got to get in there with the whole team, the whole family, right?
Right.
So thank you for that. It makes the biggest difference. And once you win the family over,
Right.
that birthing person loves you and all is well. All is right in the
Yep.
world, and they just have such a different experience. I just want to go into the chat for a little bit. It's the birth plug is here and says, I love this advice. Lala, she says, absolutely. And every time, she says, absolutely. And every time I find a provider I can trust, they leave the practice. And it does happen. It does happen. But there are more people out there. And as you can see, as we start to bring down those silos, we can start to connect more and be able to say, hey, listen, you're in New York or you're in the Virgin Islands. I may have somebody for you, right? So really being in these spaces is powerful. And Dr. Farrington says, at least be there on the phone when you're in the, during the prenatal visits. If you can't be there in person, at least be on the phone, right?
Listen, FaceTime is serious nowadays. Get on a phone, get on a FaceTime. Right. FaceTime is real.
It's real. I have a question from one of the attendees. It says, as a pregnant person, should I be asking for what I want? For instance, is it okay if we wait for my midwife to draw blood? Or can I get up now or remove the monitors? Or should I stare directly or state directly, I prefer to wait for my midwife and prefer not to be on the monitors? What's some advice you would give to this attendee?
So the question is really, should you present your wishes as a question or as a statement? I think that you should present them as a statement, but in a way that we just mentioned, not a charge statement, right? Because it's within your right. So to say, I would prefer to wait for my midwife to come before you draw blood, it's a complete statement. I think that's fine. I mean, is it okay? You can say that, but then you're giving that person a chance to say, no, it's not okay. And then are you going to take a step back, or are you going to, I think just making it plain as a statement, I would prefer to wait. I would prefer for this. I think will be received well. It doesn't feel charged. It feels like you saying you're in charge of your care, which you are, and that you have preferences and you're allowed to have preferences.
Absolutely. I always tell people, read the room. We're so good at reading rooms nowadays that if you walk in and person's kicking the chart and knocking down the things, you might just be like, we just, ooh, 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 wait a second. Ooh, you know what? Where's the bathroom? Listen, I've seen patients go to the bathroom. We lose patients. Be like, wait a second. They back from the bathroom yet? They peeking out, looking to see if the midwife's out there. Like, read the room. Listen, I don't ask no one a question because they might not give you the answer you want, right? Don't try that thing about hiding in the bathroom. Whoever wrote that down, don't hide in the bathroom.
Oh, that is funny. No, it's true. And I think to your point, again, if there are opportunities to have these conversations prior to getting to the hospital. And quite honestly, I think that is the best time to have them before you get to the hospital, because any one of us that end up in a hospital for any reason, there is a level of anxiety and fear when you walk into these buildings because you're vulnerable, right? You're vulnerable, and that it just adds to the anxiety. So I think the more information, questions you can ask, the more information you can gather about the facility, about, what your options are, what the team is like. The more information you can get prior to being admitted, the more empowered you'll feel, I think, and the less anxiety you'll feel in terms of like what to expect. So I think the more questions you can ask prior to, go on a tour of your birthing facility, right? Like really get as familiar as you can with the environment. And I think that helps to decrease some of the anxiety, and you'll know where you're going in, when you get there, you'll kind of at least have an idea of what to anticipate.
So I got to put a plug in. I got to throw a plug in there because I am a community birth provider also. So I think it's important that people know they have other options. Like we keep talking about hospitals, but there are people that choose to birth in birthing centers if there are birthing centers in their area, and low risk individuals can choose a home birth, right? So I think that people should match where they would like to birth with what feels uniquely good in their souls, right? Low risk patients are people without comorbidities, not at increased risk for mortality and morbidity. Having a home birth is a good option. If there are birth centers in your area, that's also a good option. I'm going to go on my soapbox and preach and say in the next few years going ahead, Really sick people should be occupying the space of the hospitals, and low-risk patients should be delivering their babies in places that is uniquely almost like home, so that we can really have an eye on the people that are at increased risk of dying or having near miss during the birth or postpartum period. So let's not negate the fact that there are a good less than 10% of people all around the world having scheduled, like planned home births, right? So I think that's also something that people should interview people for. Am I a candidate for a home birth? Am I a candidate for a birth center birth, right? Oh, I have diabetes and hypertension. Maybe I should be at a hospital. Maybe I have to be with a doctor, but maybe I can be co-managed with some midwives that work in a hospital. So knowing that there's different roles and places where people can ultimately have their child in a safe manner.
Absolutely. Thank you for that. Lala has a question in the chat. She says, how do you navigate not getting bullied in the hospital when you're giving birth naturally? And you're asking to have no IVs connected to you. This has been a struggle for me, and I've dealt with retaliation before. She also mentions advice on resources and information on a potential unassisted birth, like using a doula.
So I'm gonna go to the first question. I'm gonna throw the other question to Rakaya and see if she dodges to the right.
I'm here like, let's see. These are excellent, by the way.
You see, I jumped on the first half of that question. So your soul is not aligning with the hospital, because if the hospital policy is for you to have an IV and you don't want an IV and you're a low risk patient, that's something that that's where you're going. That's what they're going to require of you. If there's a way that you can get out of that, ask for the policy that everyone admitted needs to have an IV. Can I have an intermittent IV access, meaning they put something in, but you're not tethered to an IV pole? I would get some more information on that, because I don't believe it is mandated that every person that walks into an obstetric unit or birthing area needs to have an IV, but you have to see what the hospital policies are. And I'm just going to plug, unassisted home birth can be risky. I'm telling you, as a home birth midwife, I've had patients bleed. When I say bleed, I'm talking about bleed, right? People do it around the world every day, but know your risk factors. And I would say, find a midwife. There are midwives in the community, CPMs, certified midwives, licensed midwives throughout the United States that are capable of handling birth in the community setting. You never want to be alone and have something emergent happen to you and not have someone that can call 911 or do something to help you navigate that process safely. Sorry, that's just my thought.
Absolutely. Thank you, Dr. Hines. Rakaya, you want to add anything?
Sure. I was going to say we'll go backwards. So I agree with Dr. Hines. I know that there are times, even patients of our practice, who maybe things speed up very quickly and we're on the phone, and before I know it, I'm hearing someone push on the phone and I've got to walk people through having an unassisted birth at home, but that's an unintended, meaning they're in contact with the provider, maybe EMS is on the way, because as Dr. Hines mentioned, things often go well, but sometimes things don't. And you want to make sure that you have emergency care available for you for bleeding, to help resuscitate your baby, all those sorts of things. So not something that I recommend, in that I would rather you find a provider that you feel comfortable with, who hears you, who listens to you. Maybe that's a birth at home, maybe that's a birth in a birth center, maybe that's a hospital birth. And then in terms of advocating for yourself, you read the tea leaves, as my friend says. You look at the red flag. So if you mention to your provider in a visit that it's important to you to not have an IV, that you're planning an unmedicated birth, and your provider says, wonderful, that happens all the time. When you come in, you just have to mention to the nurse that this is your desire, and if you need antibiotics or something else, we'll approach the conversation. That's very different than, oh, we don't do that, right? If you get a, oh, we don't do that, then it's time to look for another facility. If we get a, absolutely, and then you get there and you feel a little bit of resistance, you lean on your provider. Because what I want you to know is this is your birth experience. This is your baby being born. The same way you would advocate for yourself when you're buying a new car or a house, and you'd put your foot down and you'd advocate for the things that you want, you've got to bring it into this space. So if somebody thinks you're difficult, but you are getting what you want and you have a safe delivery, that is your birth story. They'll go on and care for other patients. Their day will continue after you. So I don't want you to take a step back and not get something that you need because of how you think you're going to be perceived. You advocate for yourself in a way that is kind. You lean on your provider, right? You don't have to be a referee in your birth. That psyche is real. You are focused on your body and your birthing experience. So if something isn't going your way, you lean on your support people, you whisper to your doula, to your partner, to your midwife, and you let us handle that.
I don't have a problem
Absolutely.
being the bad guy, right? At the end of the day. And just to go back on roles, doulas are trained for mental and physical warfare, where your healthcare provider, that would be a midwife and doctor, are trained to diagnose, treat, and manage healthcare related things, right? So I just want to make sure that we're understand doulas shouldn't be, most doulas don't check patients. Most doulas not trained how to handle postpartum hemorrhage, or if the cord pops off, or if the baby is not breathing. They're there to help you negotiate getting a baby to rotate from posterior to anterior, or maybe do hip squeezes, or help you to come back to your breath. So whatever you set yourself up, make sure you're setting yourself understanding each person's role and function, and that you have a safety net with whatever you do, because we can't talk people out of decisions for which they want to do, but make sure that you're entering into something that you're fully aware, that you have a plan A, B, and C, because emergencies happen in a dime with regards to obstetrics.
Absolutely, 100%. And then I just wanted to piggyback off of that, making sure you understand as much as you can, to your point of doing that research, right? What's going on with your body? Some people have some, there are some complications that do arise occasionally in pregnancy. And so making sure you understand if that is something that happens, being able to ask the right questions, and to Rakaya's point, and also to Dr. Hines' point, knowing that when you ask these questions to your birthing team, wherever they may be, whether it's at a home birth, whether it's a hospital birth, that you'll know based on the research that you've done if that answer or that recommendation is the right one for you.
Right.
Because you just want to make sure it's shared decision making, yes, but at the end of the day, it is your experience, and you want to go in there as empowered as you can be. So
Right.
thank you for that. I have another question in the chat, and I know we're at 2:46. I think we have a little bit of time, and I'm not sure
We're doing good.
if people can come off mute, but if not, you can definitely keep putting your questions in the chat. I have a question. It says, how can we get doulas more Medicaid reimbursement?
Ooh.
Yeah,
Is that person from New York?
it doesn't say. If you want to put your state in the chat, or if you want to put it in the Q&A, that's fine, because I know the Q&A has come up anonymous.
So New York right now just jumped on the bandwagon. Our governor signed into January of this year, 2024, that doulas will be paid through our Medicaid patients. Those are like Fidelis Health First. There's monies allocated for payment of doulas during the prenatal and the postpartum period. So we need people, it's all fun and games, but we need people to also lobby for the rights of the birthing individual. That's the only way things will change. So right now in New York, the doulas in New York are applying for NPI, National Provider ID numbers, and then they have to get on a list, and then they'll be able to submit a bill like a provider for care that they render to patients during the prenatal and postpartum period.
Well, thank you.
Mm-hmm.
Do we have any other questions? If we don't, I have one question.
Okay.
Give it a few minutes. Okay. We talked a little bit, thank you for that. And I think it is state, it does depend on your state. And last year I did take some time to go to Washington, D.C. as an advocate. I went with my professional organization, A1, and it's our nursing organization, our governing body. And they held a lobby day, and I was so scared. Oh my God, I was so scared. It was nerve-wracking. But then I realized I was blessed with a very loud mouth, and I love justice. And so it kind of worked out for me. And everybody was like, why did you think that wasn't for you? And I was like, I don't know. But you get this day where you get to go to the staffers and the Congress people, and you get to say, hey, this is our experience. This is what we need. And this is what we're advocating for. And most often than not, They don't know. They don't know what we need. They don't know the difference between the different roles. And so, to your point, if we're out there advocating for doulas and for Medicaid reimbursement, we're out there advocating for birthing people's rights, right? Our voices will be heard. And actually, a few months after I went to advocate and lobby, one of the senators granted like a couple of $1 million out in Suffolk County, New York, towards maternal mortality, combating maternal morbidity and mortality. So it's very empowering. And so those are some of the ways. I know, politics is always kind of it's funny, but it's really important that we use our voices and speak to the people that are making the decisions so that they can make informed decisions, if that makes sense. So that was my little 2 periods and a comma. I love it. I'm using it forever. Just want you to know that. So I do have a question. We talked a little bit about it earlier. You mentioned it, Dr. Hines, and this is for you and Rakaya, for both of you. With the last few minutes that we have, can you discuss, we talked about VBACing, right? Vaginal births after cesareans. And I wanted to know if you both can share some of the unique challenges and considerations for Black birthing individuals that do want to pursue a VBAC. What are some recommendations that you would give them?
Okay, so I'm going to start because I did my doctorate on vaginal birth after cesarean section and identifying characteristics of success. If we're talking about Brown and Black women, let us really go back on history and understand that systemic racism still occurs in hospital facilities throughout the world. Plain and simple. Now that we have that understood, so that's the first layer, right? The second layer is, back in the early 80s, like 1980s, insurance companies stronged arm providers by making them have patients who were not suitable candidates for a vaginal birth after cesarean section try. And then what then in turn was people who were not suitable had uterine ruptures, people were dying, people were losing blood, and so forth. So they basically came with that slogan, once a C-section, always a C-section, right? And then they made regulations much harder for individuals to get it because you needed to be close to a hospital or in a hospital where anesthesia was readily available or a blood bank and so forth. Then they developed a tool that helped to identify, that was one layer. Then they developed a tool that was based in racism to give a calculator to say your success rate on having a vaginal birth, but it threw race in there. So here you were going for counseling to get your risk and benefits for trying, and Brown and Black people being singled out again with an app that was supposed to help promote vaginal birth after cesarean section. That's a third layer. So then everyone was educated and found out that, once a C-section does not necessarily mean always a C-section, but then they could not find providers that were willing to give them a try because they didn't want their malpractice insurance to go up. So just giving y'all a little history, okay? So then what should patients do if they really want to have a trial of labor? The first thing they need to do is understand the risk and benefits of having a vaginal birth after cesarean section. So what are the risks, Heather? The risk is less than 1% can have a uterine rupture. So how do I safeguard myself on not having a uterine rupture? Most hospitals train their residents to do better closure of the uterine lining. So that part gets fixed. So we'll give that a check. Allowing your uterine lining to heal, that means pregnancy spacing. The research says that you should give yourself at least 12 months, but 15 months when they did radiographic imaging of that lining, noticed complete healing. So giving yourself at least a year to 15 months interval spacing. So from the time you had the C-section till the time when you get pregnant. So interval spacing, good. That's number 2, check. 3, finding someone who supports, not tolerates. What are you saying, Heather? Supports VBAC rather than tolerates it. Yeah, you can come to me for a VBAC, but at 39 weeks, I'm gonna book you for your C-section, should be done at 40 weeks. Or yeah, it's okay. I fully believe in it, but my other 2 partners don't believe in it. So we're gonna induce you on the weekend I'm here so that you can get it done. That's tolerate, that does not support. So Heather, where do I find someone who supports VBAC? Well, listen, social media is a thing, right? So getting into a nice Facebook group in your area, they have these mommy and me's of Main Town everywhere. Every town has a Facebook group. There's Facebook groups for VBAC, Facebook groups for trial of labor. Go on there and find a provider in your area that supports VBAC, who's not going to talk to you about induction of labor, who doesn't mind starting a little Pitocin, won't strong arm you into getting an epidural. You have to do some research on this, but you also are going to need to, one more check, unpack the fear of the C-section. So you won't ever forget it, but you're going to have to unpack that so that you can open up new, so that you can have a brand new experience. So you got to do some childbirth education. You have to get a doula because you got to get rid of that fear, and you need someone to support you. That means when you have that first contraction, you're not, oh my God, I got to go to the hospital, right? No, the contractions are 5 weeks apart. It's okay. Like, come back home. You'll be fine, right? So you definitely need to unpack that fear so that you can release, because when that fear is at bay, then your body is able to do what it needs to do naturally.
I love that. That was excellent. I have no periods or commas. That was amazing. What about you, Rakaya? Anything?
Listen, when she starts pulling out the fingers and does the A, B, C, D, 1, 2, 3, I know I'm done. Amen. I have nothing to add. Nothing to add.
I want to thank you for that, because I think so many times we don't know the history of how we got here and how just the influences throughout in medical training and in nursing training, right? Like, we don't ever truly understand how we got here until we dig a little deep, and you did a whole, I mean, that was amazing, and it all makes sense. Now I'm going to start Googling, do my own research. Actually, I'm not going to lie. I am lucky enough to have Dr. Heather Hines and Rakaya's phone number. So y'all are stuck with me forever, just so you know. Okay? Just
okay.
saying. Wanda Day, she's in the chat. She says, my first pregnancy was an emergency C-section in Philadelphia. Was told once a C-section, always. Her second child was vaginal. I was blessed with a doctor who listened to me and informed me, informed what I said was, and informed me that what was told to me was not true. It depended on why I had the C-section. He was also a white doctor. Also, I was in a domestic violent relationship, and he referred me to a domestic violence counselor. This was during the early 90s. And I think thank you for sharing that, first and foremost, and for your transparency and your vulnerability. I think that's a beautiful story. And I think it's important. It goes back to what Dr. Hines said earlier. You want an energy that aligns with your soul. And they won't always be Black, or they won't always be white, but that energy that you feel safe in is so important. So thank you for sharing that.
I just want to put one caveat on that, just in case anyone's watching this. Reasons for the C-section are very important, right? So non-reproducible factors. So if the first baby was breech and the next baby is head down, breech means the butt's presenting, and the next baby is head down, you should try for labor, right? If the baby's heart rate didn't look good on the first time, this baby's heart rate's looking good, you should try for labor, right? Your blood pressure was elevated that last time, this time the blood pressure is not elevated, absolutely. Things that you should say, but doesn't mean that it's negative. Say you got to fully dilated and you pushed and the baby didn't come out, maybe the baby was sunny side up, right? Maybe you need to do some more work with your pelvis and your hips to get that to become a circle rather than a square. Going to see chiropractic care, staying physically active, doing things like hip openers helps to help that outlet so that baby can come down. So this is once again where you get that doula. You might join a nice prenatal yoga class. You're going to do something that's going to help to educate you, spinning babies, that's going to help to educate you so that you can help to facilitate getting that baby down and out. Active, you got to stay active in your pregnancy with having a VBAC or having just a regular vaginal birth.
Thank you. Thank you so much. And then with we have 2 minutes left, but we have one more question. I do want to reach Patrice Antoine. She says, what is the average recovery time for vaginal versus C-section delivery? I will likely be delivering in a hospital and want to ensure I'm not being pushed out during my stay.
So I'm going to give you 5, 5, 5. Most hospitals will kick you out of the hospital. A vaginal birth, anywhere 24 to 48 hours. And if you have a C-section, 2 to 4 days is the time that people are usually dismissed from a hospital setting. But every postpartum person that has a child, either through the vagina or through the abdomen, need to be in bed for 5 days. I don't care what you say, how many kids you got. We're talking about perinatal mood disorder. We're talking about overstress. We're talking about bleeding. We're talking about preeclampsia. We're talking about all the things. You need to be in bed for 5 days, right? That means in the bed. I don't care whose bed, but in the bed. Then the next 5 days, you need to be on your bed. That means the first 5 days you're in the covers. The next 5 days, you got one foot on the floor, you got one knee up on the bed. You're near your bed. And then the last 5 days, you might leave the bed, but you come back. You're near it, right? And this is shown to decrease, the tiredness, the fatigue, decrease the baby blues, the postpartum depression, all those things, because you're allowing your body to heal and rest. We're in a society for which we're always moving. So if we can move into the mentality that I just gave and I need to take back, I need to refill my tank, I need to be able to return, you'll do much better. Everyone heals differently, so we can't quantify, how quickly it'll take you to snap back. But I'm going to tell you, if you rest and allow your body to recharge, your snapback is going to be so much easier.
Absolutely. Thank you, Dr. Hines.
I love that question. I love the energy behind it, and that you are already moving slowly, right? So how long before they push me out, which is very different than what I sometimes hear, which is how soon can I leave? So keeping that model of moving slow and allowing your body to heal is so important. And the other thing is, after an uncomplicated delivery, you might feel well. Sometimes Dr. Hines' clients want to get up and run down to the kitchen to get something, and they're moving around. But the thing to remember also is, if this is your first delivery or postpartum experience, and you plan on breastfeeding your new baby, that also takes time. That's a skill that you were not born with. It's learned, right? It is natural, like walking, not like breathing. It takes some assistance. So sometimes that extra day, even though you're feeling good, you're sitting in the bed, you have your home clothes on, but you know what? That baby now is a little more alert after that first 24 hours. And now you have lactation support, you have your nursing support, you have people who are there assisting you. So maybe you stay that extra day, not just for your own physical recovery, but because you know it's going to help you on your breastfeeding journey.
And thank you so much. This was an absolute honor. We are at the 1 hour mark, but I knew this was going to be an amazing conversation. I feel like we need like a continuation.
Part two.
We need a part two. So I want to just thank you both so much for sharing your wealth of knowledge and really giving our attendees really key takeaways, action items that they could do, because I think that part is so important. A lot of times they want to do something, but they're not sure where to go with it. And you ladies did a fantastic job of really giving key takeaways. So thank you so much. And I also want to thank everyone who spent their time as an attendee. Thank you for your questions. Thank you for your transparency and your vulnerability, and for sharing your stories. And thank you also to Birthing the Magic Collaborative for having us. And we look forward to doing this again. And Dr. Valentin is in the chat. I'm going to end with this. She says, we need more midwives, and OBs don't talk like me, don't talk like this. Actually, I do know OBs that do have the hearts of midwives. I have to say, they are phenomenal. So it really goes back to get with the team that aligns with your soul, and don't be afraid to ask questions and to do your research. All right. Absolutely. And thank you all. This is excellent. Thank you all for coming.
Thank you.
Thank you. Happy birthing, and happy National Black Maternal Health Week.
Yes.
Thanks.